Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. A type of leukemia is the most common childhood cancer, and doctors have been looking for ways to reduce its recurrence. A recent national study, which involved 26 kids from the Upstate Cancer Center, seems to be a huge success. Here to tell us more about it is Dr. Melanie Comito. She's a professor of pediatrics and the division chief of hematology and oncology at Upstate. Welcome back to The Informed Patient, Dr. Comito.
Well, thank you for having me.
I understand this was a study organized through the Children's Oncology Group. Can you tell us a little about this group?
Children's Oncology Group, it's an organization funded by the National Cancer Institute, and it consists of over 200 centers across the United States and Canada.
So a lot of the children in the U.S. that are being treated for cancer would maybe be at one of those institutions.
That is correct.
So do they organize the majority of the trials for childhood cancer?
Yes, the Children's Oncology Group is the main source of clinical trials for childhood cancer. In childhood cancer, unlike adult cancer, the majority of children under 16 years of age are treated at centers associated with the Children's Oncology Group.
I see. Now, what can you tell us about this particular leukemia that's the most common childhood cancer?
This is acute lymphoblastic leukemia, and about a third of the children who get cancer have that type of cancer. There are two different types of acute lymphoblastic leukemia. There's a B cell type and a T cell type. The B cell type is the most common, about 80% are that type. So we're talking about one of the most common childhood cancers that we see.
What are the typical symptoms that the child would exhibit?
Usually children come in with symptoms that are very similar to the symptoms that make them go to doctors in general. They could have fever, aches and pains, especially in the arms and legs, bruising. They can eventually look pale. And in general, you get these kind of symptoms because in leukemia, the blood cells that are made by your body get crowded out by these abnormal cells. So you quit making the normal blood cells.
What age or how young do you see children with ALL?
You can see ALL down to birth, but the most common age is 3 to 7 years of age.
And is there a treatment or how is it normally dealt with?
Chemotherapy is the main treatment for childhood leukemia. Treatment consists of different phases, with the more intensive phases in the first year, and then eventually what we call a maintenance therapy with oral medications. But treatment can last from 2 to 3 years.
And what is the outlook for someone who's diagnosed with ALL?
In general, the outlook for nearly every child with ALL has been good. The majority will be cured, but the recurrence risk as a whole is 10 to 20%. And that risk depends on which category ALL you have.
And when we talk about recurrence, does that mean once the child is older, or could that be just a few years after they finish treatment?
Recurrence usually happens while they're on treatment or within the first couple of years, but there can be some later recurrences, but this isn't something that comes back once you're an adult.
Okay. And is the outlook worse then if you've got recurrence?
This disease can still be cured if there is recurrence, but it takes retreatment with chemotherapy. And in many situations, the addition of therapies such as a bone marrow transplant or these newer CAR T cell therapies, which have a lot more effects on the child.
So it sounds rather involved, that the treatment really requires some expertise in managing it.
For the recurrences, yes.
Well, let's talk about the clinical trial. What is BLENA?
So the Children's Oncology Group did a trial for what we call standard risk acute lymphoblastic leukemia. Standard risk means these are for children ages 1 to 9 years of age that have kind of a better prognosis, but still about 10 to 20% of these children would relapse. So in this trial, they're testing a new drug called blinatumomab. Blinatumomab, or what we call BLENA, is a targeted immunotherapy. So it's not a true chemotherapy drug. What the word targeted means is it's programmed to recognize something very specific about the leukemia cell. And immunotherapy means it's going to target the specific leukemia cell and use your immune system to get rid of that abnormal cell. That's different than how chemotherapy works. Chemotherapy is just kind of hitting rapidly growing cells, but it also hits normal cells. So Blina is what we call antibody that has two arms to it. One arm grabs the leukemia cell, so it recognizes something unique to a B cell. And the other arm grabs your T cells in your body and it brings the two close together so the T cell, your immunity, can take away the leukemia cell.
So do they work together, the chemo and the Blina?
Yes. Blina is not a new drug per se. It was already FDA approved for children with relapsed ALL. And this study, it was testing it for newly diagnosed patients for adding it into upfront treatment.
So the objective was to prevent the recurrence, to give them this drug before there was a recurrence to see if it could keep it from.
That's correct.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Melanie Comito about a clinical trial involving children from Upstate that was looking at a way to reduce the recurrence of a specific type of leukemia. Now, how did you find 26 kids who were willing to participate in this study at Upstate?
It has been standard throughout my career to offer clinical trials through the Children Oncology Group for children with acute lymphoblastic leukemia. So for the past 35 years I've been practicing, most children with ALL do participate in clinical trials. Most families, when offered the clinical trial, choose to participate. The Children's Oncology Group has an excellent track record in improving the survival in each ALL study that they have done.
So there were 26 kids from Upstate, but there were many more that were involved in this trial across the country. Is that right?
That's correct.
Now, what did the children have to do as part of the study? What were they required to do?
So this was a study just for children who were 1 to 9 years of age who had white counts under 50,000. So that's what we call standard risk ALL. All these children received the usual 3-drug induction therapy that we've been using successfully for 40 years. And then at the end of the initial 4 weeks, the children are assigned to different risk groups, depending on how quickly their leukemia cells went away and the genetic makeup, which we know now by the end of the 4 weeks. So the children were divided into 3 groups. There's a standard risk favorable. That's about half the children. They already have great therapy. The cures are very high. There's a standard risk average. That's another 25%. And then the last 25% fall into standard risk high. And as you keep adding favorable, average, high, the overall cure rates from the standard therapy we gave in the past is a little bit lower.
So how many weeks were they taking the medication?
For the children in the standard risk average and the standard risk high, they were then asked to participate in the second part of this study, which was then giving Blina as a randomized question. So that means you got Blina or not by chance. We always have a standard arm, and then we add something to it to see, is it going to improve treatment? Is it going to keep treatment the same? Are the side effects different? And to be able to conduct the study, you need lots of patients and you have to randomize it.
So what were the results?
The study showed that for children with standard risk high BALL, the use of Blina improved the survival 10 points from 85% to 95%. That's 10 more children out of 100 that were cured. For standard risk average, the improvement was more modest, but it still went from 93 to 97. So all of these children in general had the outcome very close to the standard risk favorable subgroup. I think curing 10 more children out of 100 is huge.
How long after these results until the FDA would approve the drug for this particular use?
So the study was unblinded last summer, I think at the end of June 2024, when these results were found. The FDA approval, I think, came within a month or so afterwards.
When we were talking about what the kids had to do for the study, the story that I read in the newspaper was about the backpacks that they had to wear.
Yeah, Blinn is a continuous infusion. When the study first opened, that was kind of a hard sell for families. Like, oh my God, I'm going to be hooked up for 4 weeks straight. We actually had a couple who refused the randomization. Oh, I don't want to put my kid through more. But then once the results came out, families are clamoring for it. So we had to come up with the logistics of how to do this study. We bought our own pumps. Our investigational pharmacy here did all the supporting the pumps and with our nursing staff. And then we had to buy the little, because these kids are little, the backpacks that were the right size. There was somebody on Etsy that was making them. Well, that's what we used our local philanthropic funds and St. Baldrick's to help with those expenses. They have to come twice a week to change the bags, so there were extra visits, and we help supply gas money. And those are the things that aren't covered by the trial. Blinn is an expensive drug, but it quickly got the FDA approval, and now insurance companies are paying for it.
So at this point, do you recommend that kids with ALL all start this treatment?
So Blinn is recommended for all children with B-ALL, except for those with that standard risk favorable subgroup. The patients receive 2 4-week blocks where they're getting this medication. It starts about 2 to 3 months from diagnosis. It works better when you have less of a disease burden.
Well, let me ask you about sort of the longer term outlook for the kids who survive ALL. Are they at risk for recurrence of leukemia in adulthood, or are they at risk for other types of cancer in adulthood?
So in general, the long-term outcome is excellent. The children grow up and lead relatively normal lives. There are risks for late effects, and we recommend that all children successfully treated for B-ALL be followed in a late effects clinic. When you're adding new drugs like blinatumomab, we do want to follow these children to see if there's late effects. Will there be a change in their immunity? Will they be at risk for autoimmune disorders? That's still the unknown. That's why we're very careful when adding new medications to a chemotherapy regimen.
So does that mean they continue seeing an oncologist for the rest of their life?
We see these kids in our regular oncology clinic till they're about 2 years off treatment. And then we transition into what we call our late effects clinic or our survivor wellness clinic. And this clinic focuses on how to stay healthy as they go into adulthood, and then also to help the child, who was often very young when they were treated, understand what treatments they received, because we know these children are eventually going to move away from our center. They're going to go on, and we have to really empower them with the information that they can take to their primary care physicians.
So do you think the success with Blina opens the door for new treatments of other types of cancer?
Definitely targeted drugs are becoming more a part of cancer treatment. And the reason for finding all these new targeted drugs is we've been able to do a molecular analysis of many, many different cancers. And so once we find a mutation that is a target, then you try to make a drug that targets that mutation. And that is much more specific against the cancer.
I see. Well, thank you so much for taking time to tell us about this, Dr. Comito. I appreciate it.
Well, it's always exciting to talk about and to be able to talk about this wonderful addition to leukemia therapy. I mean, I've been practicing for 35 years, and it's getting to the point where almost everybody with standard risk ALL is cured with upfront treatment.
That's encouraging. My guest has been Dr. Melanie Comito. She's a professor of pediatrics and the division chief of hematology and oncology at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.